Here's a question that says, I need some clarification on treating piriformis syndrome with contralateral glute max, okay? We can wait with that. But I can already answer the question. It's coming up. Okay, we got a whole piriformis section coming up, but I'll still clarify it when she gets back, okay? Here's a question written by Bobby. I'm just joking. Just joking. What stability measures need to be taken for right iliolumbar ligament instability and laxity? Man, that was insightful. What stability measures need to be taken for right iliolumbar ligament instability and laxity? We just kind of covered it. The stability measures you need to take is correct respiratory activity. Because remember, the iliolumbar ligament, if it's kind of stretched out, you need, might want to write this one down. Iliolumbar ligament laxity needs two things working concomitantly together. IOs and TAs on the left side, IOs and TAs on the left side, and right low trap and tricep on the right side. That is a postural respiration course. So IOs and TAs on the left side, and right low trap and tricep on the right side. So to reduce the iliolumbar instability let's figure out how that happened. You overcompensated. The spine is going to the right side. You're oriented over there. And you're overcompensating. You're trying to stay neutral. And that iliolumbar ligament can have an impact on rotation. And since I'm going over to my left side to compensate, that iliolumbar ligament is getting stretched out. Remember, on this side it's extended, on this side it's flexed. And if I would stay here for everything I do, my iliolumbar ligaments would be happy. But then I got to start to twist. And when I start to twist, I'm pulling this innominate away from the spine that iliolumbar ligament is directionally obliquely going into. And so you'll see what we saw yesterday in the lab. We saw people that had way too much right trunk rotation than they should have had. Their legs went all the way over to the left side, and they shouldn't have gone that far. And if they went all the way over to the left side, we know that what's allowing them to go all the way over to the left side is that lumbar spine is going all the way over to the left side, and that rotation's too extreme. So I've got to, and these ribs are way up, and this pelvis is really far forward. So I know all that was twisting was coming from soft tissue. So you know you got a problem when a person walks in and says, Mike, my right QL area, my quadratus lumborum area is really tight, really fired, really active. My right abs are really tight and really firing. My right intercostals are really on. You know you've got some iliolumbar ligament instability. So to answer the question, what stability measures? Well, you got to get a zone of apposition established on the left side, coupled with really good awareness on how to keep yourself stable when you're in the left hip. And to do that, your right side needs to be working when you're on the right side, but it needs to let go when you go to the left side. So to finish this statement up, I would want to put you on a program with left myokinematic thinking with right trunk rotation, because if I don't get left myokinematic thinking with right trunk rotation, my right trunk rotation will be following the right myokinematic thinking. So if I'm on my right side and I got all this right trunk rotation, why do I really need to go over my left side? I'm happy here. My back doesn't like it, but everything else I'm doing well with. So to seal that process up, you want to get them over to the left, ground them, and then get that right trunk rotation that now should be a little bit more limited because you seated them on the left side. And that's the answer. If you don't, here's the question. Do you want to see less trunk rotation when they lay on their back to the right? Yeah. You want less right trunk rotation, which means you're now getting them more aware of right trunk rotation when they're on the left side. You would take this program whether they're patho or not patho, patient A or patient B. You get them to drive and live on which side, Lydia? And then you start introducing what? Left arm reaches, right trunk rotation. And we call that right low trap, right tricep engagement with left ZOA. And that's another course. But it's a great question. So wouldn't you need this mild kinematic course principles to even go into the right trunk rotation principles? Yeah. So this is a question that ties 2 or 3 courses together. It's a good question. Whoever answered, did I answer it okay? Did that answer your question? Okay, let's go to another one. Can you fix and maintain neutral AFIR positioning without addressing the respiratory component? No. Because if you are going through AFIR neutrality repositioning and you're breathing only with your neck, there's no way you're going to fix neutrality. So you at least got to be aware of how to what. Are you ready for this one? You can tell everybody what they got to be aware of. What does that say on that board? Say it out loud. You've got to inhale, you got to exhale, and then you got to pause. So I can't say yes to this because if you're inhaling and you're inhaling and you're inhaling and you're inhaling, you'll never fix neutrality. You understand what I'm saying? You inhale, relax. Inhale, relax. Inhale, relax. Because the only thing that's exhaling is your weight pushing it out or extension pushing it out, but no obliques, no glutes, no hamstrings, no rotation, and you don't pause after it. You're constantly hyperventilating, and there's no way you're going to be neutral. I could never say yes to this. How about this one? Could you fix, I don't like the word fix, can you maintain neutrality, AFIR positioning, without addressing the respiratory component when a person has a thorax that's neutral? The answer would be what? Yes. If the thorax is neutral, the brachial chain isn't an issue, the answer to that question would be what? Yes. Because you don't have to contend with this after you got this. But with the way it's written, I could say no, because I don't know what you're doing with this thorax. So whoever wrote the question, did that answer the question? That makes sense? And anytime you guys disagree with anything on the way you thought were taught it, let me know. So the answer to this question depends on what state the thorax is what really in. The answer would be, do you have a ZOA or not? Do you have the ability to exhale and what, everybody? Pause. Do you have that ability to pause and exhale, which means the next breath will be brought in with your diaphragm. But if you're using your neck, there's no way you're going to maintain neutrality. You'll drop right off. Can you explain how the left AIC can impact the sympathetic system? Oh my goodness. There's a partner in the room called Dr. Wise that will tell you, man, you guys, whoever asked that question, you realize I'm about ready to go off into a hole like no other, right? She's going, oh my God, reel this baby in. Or is it more dysfunctional, or is mere dysfunction required to disrupt it? I'm not sure what that means, but I'm going to say this to you. I'll try to answer the sympathetic and parasympathetic drive here. This AIC pattern, whether it's a left one or a right one, which would be both, this left AIC pattern or this right AIC pattern with the left AIC pattern is driven off of a word called dopamine. It's called extensor tone. It's called I can't get enough. It's called I'm living on drive. And if you can't shut that system down, then you're also going to be challenged by keeping the left AIC a hemi-operational process. The left AIC is not a bad deal, but it should be hemi. You go to the left side and then you go to the right side. But you're never going to drop off one side that's locked up if that pattern is there, because you got to have more. You got to have more strength, you got to have more power, you got to have more tone, you got to have more control. Just say the word more, and then you're talking about autonomics. This is about as simple of an answer I can give. If you want more, you will not be able to do more bilaterally, binocularly, orally, do you follow me? Bipedally. You won't be able to do that. Because the more you want, the more the autonomic nervous system is going to keep you on what? One. And the prediction is you already know which one. You already know you'll be over this right leg. You already know you'll be doing things with the entire autonomic system based on that alone. So can you explain how the left AIC can impact the sympathetic system? The left AIC is impacting it because it's giving you more of one. And if you say more of one, autonomically, you're driven around that more. Why would you want more of that if it's going to make me more parasympathetic? People don't know how to relax. Why would I want to be relaxed when I got, 14 hours to work to do in 7, and I got work at home that requires 10, and I got work to do for next week that requires 3, and I still got work to do that I didn't get last week done, which now I'm down to nothing. Why would I want that? I got to do more. So yeah, it drives it. How do people become stuck in the left AIC or right AIC pattern, either pathologically or non-pathologically? Well, that's a very broad question. I'll tell you what the one thing that keeps you stuck in either patho or non-patho. This is a real simple answer. Behavior. Your behavior. You ingrain yourself around behavior. You sense things, you feel things, you operate on behavior. It is therefore, the adjective before behavior is learned. You learned a process of behavior that complements the way we are built inside. You are who you are because of the behavior around the pattern that you've established that makes you comfortable. So the answer to this one's pretty easy. How do people become stuck? Well, people don't like to listen to other people if it's not going to complement their behavioral thoughts. People don't want to get into programs that's not going to complement their behavior experience. Just fill in the blank. I think we can go further. Either pathologically, people will do wrong and bad things to accomplish behavioral addictions. Is this a psychiatry? Is this a psychology discussion right now? The minute you said the word stuck, it sure is. Because I can mechanically get you out of that and show you what to do, but if you still behave the way you do, and your doorknobs will help you continue that, and the street that you drive on will help you drive that. Do you follow me? And the iPhone that you hold will definitely make sure you know that, et cetera, et cetera. Your behavior doesn't drop off that easily. So the only way you can become unstuck is you got to make sure you drop off learned, addicted to behavioral patterns. You've got to substitute that. You've got to love your left side more so at times than you do your right side. And in the beginning, it was pretty hard to stand on that block and feel my left side. And it was pretty difficult for you to pick two pretty complex ones. But now I got to get so good at that I got that. This is a behavioral freak, I'm telling you. Look at my calf, it'll tell you the story. I wear up my left heel. I'm a nut. I can't stop. Because behaviorally, I know I will get longer longevity if I do that versus not pay attention to what I want. Does that make sense? What's the best way you can answer this question? The best way is to get around people that do something completely opposite, different than your behavior. Gibby, what's something that you'll never do in your life?
Probably run a marathon.
What's that?
Probably run a marathon.
So Gibby, I would encourage you to go run a half a marathon and fail next year. Do you follow me? It's like, I don't really mean that. But pick something you would never do. And if you do it, I guarantee you, you'll become unstuck pretty quick because it's a pattern you're not familiar with. So ask yourself, we do this all the time, Dr. Weiss, don't we? All the time. What are we going to send you out of this program with that you've never done, that we're going to make you see and think and realize and feel differently? And that we're going to keep these PRI principles involved. Okay, why are some people neutral and others are not? Oh, that was a great question. Given no traumatic event character, whoa, I love that. Why are some people capable of keeping neutrality and some people cannot? What would the answer be there? It's kind of a simple answer. Why do some people walk in and do the same activity that you might be doing in the sport, but they come in neutral every time they come in? Why is some people in that volleyball team look so neutral, or the basketball team, or the football team, they're always neutral and they're doing the same program? Why is that? What's the number one reason why they can do that?
Tone and stress.
That's a big one. What's another one? Tone and stress. They can manage their tone and stress. What's another one? Let's just have fun with this one. What's another reason why?
Genetics.
Genetics is a good one. It's a good one. I can buy into that easily. What's another one?
They can get off their right foot.
They can get off the right foot. That's a given. But why? What's another reason why they can get off the right foot?
They're more aware for some reason.
They're more aware. They have more sensory capabilities of doing that. And why is that? Why is that person more aware? The answer is they understand they have two. They have 2 legs and 2 arms. What arm will that person be using? More than you guys probably do. The left. They have 2 peripheral visions. They have 2 feet. You're kind of going in the right direction. They know how to manage 2. That's a great question. That's a PRI question. And you realize in managing 2, there's always one that's going to be more challenging. And that's a gift. That is an absolute gift to be challenged, because then you got to change. These people that walk in neutral can manage the world. There's 2 of them. There's a left hemisphere and a right hemisphere. Do you think they're the same? There's a left set of lungs and a right set of lungs. Do you think they're the same? There's a left set of organs and a right set of organs. Do you have 2 hearts? You understand? They can manage what? The answer to this question is really easy. Katie, they can operate around 2. 2. They put themselves in positions that operate around 2. They listen to both sides of their head. Do you understand what I'm saying? Both sides. They have 2 personalities. They're listening to both. Great question. Sorry I can't get in more depth with that, but that was one of the best questions of the morning right there.
Hey, Ron.
Yeah.
I have a question. Do you see people get stuck in the right AIC pattern, or is it always just...
Yeah, we do. We see people getting stuck in the right AIC pattern. They're multidisciplinary, complex patients. There are people that have concussions. There are people that play flutes and violins. There have been, what's that?
Left-handed.
Left-handed people. There are people that don't know how to move outside of a scope of practice because they've been taught a certain way in a school they went to. There are people that only have certain beliefs.
So to treat them, you would do the opposite of...
Nope. To treat them, I would do the exact same program you got in all 3 courses.
But Ron, are they truly just a right AIC, or are they really a bilateral person who's got other compensation?
Which one do you think it is? They're a bilateral person who has other compensation. So I treat them just like we did before, because those are the people that probably will do some things better for you than the other people who come in pattern, because they're at least doing something opposite of what that person does. But they have the same brain, they have the same body. Do you follow me? They just compensate in a different way. And if anything, if anything, those people scare me because they're almost like pathology-oriented people. In other words, they're doing something that normally you don't see, and I'll tell you, we love it when we see it because we have so much fun with it. We know that we can get them in a baseline. Once they get back to the normal left AIC, right BC pattern, we know we're making progress. We actually want to create a normal human. And then we got to get them to what? Alternate. That was a great question. The first thing I would say to that is when we see an individual who's doing something strange with a right AIC pattern or a left BC pattern, almost hard to imagine, but I guess it could happen. When we see a right AIC pattern person come in, and let's say they're bilateral involved all the way up and down from the pelvis on up, we both sit there and say, hey, first thing we got to do is knock them off their stool. We got to completely disrupt them. And we're going to do that next year with a course called destabilization. We got to completely get you to be kind of like out of your norm and still give you the ability to sense things that's going to give you more of a normal norm, which would be your right leg. Can you imagine me telling you, could you go find your right leg first? We'll use that as a reference. I'm going to put an arch in your right foot to help you find that right floor first. Sometimes we have to do that. Now we can play games. we can start this whole process up again. We do see those patients. They're multidisciplinary-minded patients. Or dentistry, optometry, podiatry, psychiatry. Heidi, what else?
Everything.
Every
sensory system you can attack.
we have to look at. So they're multisensory, but that doesn't mean they're tough to treat. They sometimes do very well when you just introduce the word change. Are there any negative outcomes to taking PRI interventions to an extreme? Oh, of course there is. Of course, there's always. Would you want to have somebody doing a 90-90 Hemi bridge the rest of their life? No. I wouldn't want to do that. That's pretty boring. It'll drop it off. It gets old. Or you go so far in internal rotation that you actually start orthopedically see some issues arise because of it. Yeah, it's definitely something you don't want to do to the extreme. But and it says overusing the left thinking about your left gastroc, etc. I got it. Yeah, I'm not happy my left gastroc's bigger than my right, but I'm happy. Do you understand that? I'm not falling apart. I'm falling apart maybe up here, but I'm not falling apart down there. I'm happy. I'm staying neutral. I'm sure of that with my pelvis and my hip and my breathing. The point is, I don't want to drop that off because I know if I drop it off, I'm not going to feel better. You know, I've got to maintain other things. There's other issues maybe I got to look at. But overdoing something, probably with what we're talking about today, is going to be very hard to do. And I'll tell you why. You can't move a pericardium. And you can't go in there and take your right hemisphere out and put it in the left. And your amygdala is going to be different if you put it down or over to the other side. Do you understand that? And Wernicke's is not going to do much for you by putting it on the other side. And Broca's definitely don't touch it. Do you understand what I'm getting at, guys? You can't remake what you have. So you're going to be really challenged to have me say to you that you're going to overdo something in PRI. You understand that? Let's turn the coin around. If you don't do PRI, you're going to have a lot of symptomology by doing overthinking and overdoing with the normal. I'm asking you, who's challenging that in our society? Who's challenging that? I mean, really challenging that. I would invite you to think about that. Every time you take a new course, do you ever see the word left or right come up in that course? I'm going to challenge you on that. If left or right doesn't come up in that course, you're not being challenged. You're not being challenged at all. You're giving techniques that are only going to make your present activity go what? Up. I don't care what course you go to. It's got to go up because nobody challenged your left and your right side differently. Think about that. Chew on that. So the answer to the question is doubtful, because you're going to be around a lot of people who don't understand you, Gibby. Gibby, I can't imagine what people thought of you when you came back from that first PRI course. Are you drinking something? What did they feed you? They actually fed you? What did they put in your salad? Seriously, are you really going to tell me you're going to do this on your left side because you're different over there? Gibby had to defend himself. So the question is, what are you going to do so much of that that's going to hurt you? Doubtful, because your organs and your neurological system won't allow it. That's why you have a gift inside of you. It's called asymmetry. You can't mess up. But you will mess up if you don't respect the fact that you've got two. With asymmetry, that will mess you up. Let's do another one. How am I doing? Helpful? Fear resides in the hips and the pelvis. Your thoughts? Yeah, I agree with you. Fear resides in the hip and the pelvis because of inputs you receive. There's probably nothing that will carry fear like your pelvis. Your pelvis will carry a lot of fear, okay? There's books on it. But the real fear is, the fear factor that you have is totally your memory. It's based on experience. It's all brain. And fear in the pelvis and the hips is still brain. It's still a brain issue. Those are thoughts. Until that brain can get the thoughts that are pleasant and welcomed from the pelvis and the hips, you probably aren't going to be able to change that fear factor of the pelvis and the hips. Now, I'm not talking about sexual abuse issues or issues that were traumatized oriented. I'm talking about this. This is the biggest fear. You might even want to write this one down. Mike, the biggest fear that you have walking on that campus are athletes falling. Anybody doing geriatric work? The biggest fear you have, guarantee it, Drew, are geriatric people fearful of what? The biggest pediatric person in the world will tell you the biggest problem you're going to have with kids is teaching them how not to what? Fall. The biggest problem you got with the sports medicine program is making sure patients don't what? Fall. I can keep going. The biggest fear your pelvis and hip has, will I be there to support you and prevent you from what? Falling. That is your biggest fear factor. When it calls, the fear factor show, it'd be FFF. Fear factor falling, or fall fear factors. Because we all are, we just talked at lunch. My son, if you watch him, he's got this big, beautiful black eye. He fell, wasn't even drinking yet, and he fell. And we were talking about, it's better, he asked me a question, this is a true story, he just asked it. Who asked the question? Would it be better to lose your teeth or get a black eye? Who asked that question?
Chip your teeth. Chip
What's
your
that?
teeth.
Chip your teeth. Who asked that question?
You did.
I don't know. He goes, what's better? And I said, geez, a black eye. I don't know. Because he doesn't want to hit that eye again. He has a fear of that. Because it happened once. What's that called, everybody? He just made a what? I'd rather chip my teeth, he said. Because once he chips his teeth, he'll say, man, I don't want to do that again. I'd rather break a clavicle. Well, once he breaks a clavicle, I'd rather do something else. Because you just ingrained into that fall a what? A fear that had a symptom associated with it. And now you're scared you're going to hurt your eye or your teeth or whatever it might be. The answer to this question, the fear resides in the hips and the pelvis. Finish off the question. The fear resides in the hips and the pelvis because of your fear of what? Falling. And then put another word behind that. Apart. Follow me? It's not even the floor. Apart. No meaningful activity. I get touched and I clammed up. Someone tells me to breathe or lift something and I get tight because I'm afraid I'm going to fall apart. We have POTS patients walking in here every day over there. They can't breathe and they get lightheaded and they're dizzy because they fear they're going to what? Fall what? Apart. They can't handle pressure. They can't handle it. It's a great question. But most of this fear is not even real. It's a synapse. It's up here. Take the synapse away and nothing happened. I'm fine. So you got to retrain these people to have that activity that they fear accomplished without any symptomology or actual reduction of symptoms and no longer not a pelvis issue anymore. Now I'm afraid I'm going to sprain my ankle. You follow me? It's all up here, right here. One more question. To answer that question, you ever asked it? Make sense? So you're mindful. Hey, this is on a different piece of different piece of paper. I'm not going to answer that one. We answered it last night. We decided we're not going to talk about that. Wow, this is a long one. This will be the last one. When squatting and femurs go below parallel with the ground, the pelvis appears to tuck under. Is this good or bad? So when you squat, the pelvis needs to tuck. The pelvis tucks under. Is that under or over? Whoever asked that, is this under or over? Okay, is this under? So the pelvis appears to tuck under. Is that good or bad?
Go beyond parallel.
Go beyond parallel. So when you squat, if you lose your 30 degrees of lordosis, is that good or bad? Well, you guys, I'm not a weightlifter. I'm going to tell you, that's something I wouldn't want to do. I wouldn't want to rotate my pelvis all the way back and get so much flexion on my lumbar system that I have to overwork with my back to get back to neutral. I wouldn't want to do that. So it's kind of a loaded question because it depends on what you're lifting, what you're doing, and how you're using your feet to do it with. So no, I don't think it's necessarily good, but there's certain times where you actually have to do that by leaning back to pull. But if you're lifting and you do that and lean back, you're going to pull something. It's obvious you're going to hurt your back. Discs are going to push back. So if I'm pulling something like water skiing and I want to get up and I have to do a little tilt to get out of that water, that's not bad. But am I there for a short amount of time? Yeah, and then I'm going to move right out of it. So it's kind of a loaded question. Does pelvis posterior tilt when tucking under or the sacrum angle? under a sacrum angle decrease when, Mike, did you write this?
Yeah.
Can you help me with that last one? I can tell where it came from.
It all has to do is you go below parallel, not at the top, so at the bottom of the squat. And if you squat all the way down, it appears that your hip is tucking under. So the question is the hip tucking under, or are you losing your sacrum angle? Does that decrease, become less than 30 degrees as you tuck under?
The answer to that is yes. And when you tuck, is this tucking under?
Right, so is that the
That's a posterior
pelvis
pelvic
tucking
tilt.
under, or is that the sacrum losing its?
Well, the sacrum is always moving somewhat independent of the innominate, but Mike, by just a few degrees. So when you move your innominate back, your sacrum with respect to the innominate is going to be going forward because it's not going to move as much. When you move your innominate forward, this is osteopathic, your sacrum is going to move back with respect to the innominate, but not very much. Okay, that's called respiratory economics of the cranial sacral system, which I'm not going to get into. So when you start to then take it to the extreme, I'm going to lift. And when you say tuck under, are you talking about lordosis, Mike? I want to make sure that, are you talking about lordosis?
I think with strength coaches, they try and keep the lumbar spine in a neutral position of
Correct.
that 30
Correct.
degrees.
As much
So
as you
as
can.
they go down, it appears like everything is, it looks like when you see it, it looks like it's tucking under.
Well,
and the
it
strength
is.
coach says, don't do that. Then you keep that lumbar, that neutral position in the lumbar, what they think is neutral, and then they start getting spondies.
Yeah, and you said it well. First of all, when you get to 90 degrees, a 90-90, you're at the loosest position of your SI joint in your pelvis you can be in. As you start to go down, your innominates are going to start to posteriorly what, everybody? Rotate, because the knees are going which way? Forward. And as those knees go forward and you start to rotate, that's called counter-nutation in my book, of the sacrum is now going to follow the innominate more, because you're starting to go in knees to chest. Knees to chest is thoracic flexion. I would call that, as you get below 90 degrees, you're going into thoracic flexion or counter-nutation, or a sacroiliac joint that's now moving together in posterior rotation. Now your ligaments are going to hold, for the most part, is going to hold you doing that all the way down to when you get into a squat. When you get into a squat and you're down that low, you start to go back into nutation, because your center of mass has got to shift back, otherwise you're going to fall, and so you start going into counter-nutation. Also at that point, when you get below that, when you get into a squat, what we call 4 or 5, you're going to actually now rest on ligament. You're not holding yourself anymore up. So between a 5 and a 4, and you're lifting with a 5 or 4, you're not going to be able to lift a 5 or 4 if you don't go into counter-nutation. So you're going to have to extend your spine to get out from the floor to lift. You got to. And that's why these strength coaches get so upset with these PRI people, because they say, you realize you got to extend your MAC to get out of a 5. Jason, I know that. I didn't say we would do it. You got to do it. Remember, there are strengthening people out there trying to get stronger backs and stronger period. And there are people out there that are also trying to do that and have no clue on how to what? Shift. So as they come up, they're overextending because they are lifting with one leg. If they're not neutral, they're going to lift. If they're not neutral on one or both sides, they're going to lift, Mike, with one leg. Which leg will they lift with? The right. They don't have a choice. And at that point, what we're talking about becomes extremely dangerous for a disc, extremely dangerous for soft tissue of an SI joint, and more importantly, extremely dangerous for bones that then will spirally get little fractures called stress fractures, and ankles. Does that make sense? So I'm not opposed to seeing extension way down there that you can correct, because you're not lifting. It's coming out of it and going to it I'm worried about. Once you get to about a 3, like a 4 or 3, man, that's hamstring squat, baby. That's not the problem. It's going down, going down and lifting up. That's the problem. So deep squats, I'm not a fan of deep squats. Your linemen don't really need deep squats. They need power. We can get into that whole topic. We did at one time. We did talk about that. Mike has made, and I know we're not promoting products in this course, but Mike's really got some really good biomechanical mindedness to him, and he's put models together. And those models, and if you have to take this off, cut it out, but those models are available. I'm going to promote them a little bit. And maybe at the break, Mike, for anybody who wants to look at Mike, he brought a few more in, just look at what we're talking about. He'll show you how the pelvis, this is a myokinetic course, this is where we could talk about it, how the pelvis operates under levers called the femur, the spine, and the tibia. Tibia, femur, spine. I love talking about it. So I hope I didn't do anything to disrupt our thinking. Does that complement what you're thinking for the most part? Yeah.
So would you ever place a load on somebody's back if they have bilateral scores under a 3 on thoracic adduction lift
Well,
test?
I don't want to say I would never, but I would be cautious. When you get to a 3, when you get to 99 position and you have control, that's the start of a lot of sweetness. And if you can then teach people how to come out of that, come from a 4 to a 3 with a squat, or how to go deeper than 90-90, like 120, go deeper with the knees, and they maintain the ability to feel and sense both feet as they're doing it, I think you're safe. But as you go down and you find out that they become a unit, Gibby, they go down and they say, I don't even feel the 2 floors anymore. I feel 1. It's my spine. It's dangerous. Do you remember when you said, I feel the floor? If that floor is becoming more alive as you squat, Gibby, safe. You're safe, right? If that platform is more alive when you squat deep, you're safe. But if the platform goes away, I know you're lifting with pullers. You're leaving the floor. You're pulling yourself forward with hip flexors and a lat that's a puller. And once you kick in that lat that's a puller and those hip flexors that are polar, you lose the floor. And anything you fight now will not be what's in your hand. It's the body you own mechanically. Because the myokinetic property now is lost. You're not only lifting weight, but you got to de-associate lifting with flexion. You got to extend. So you don't know how to inhibit. You're constantly now pulling yourself, and when you come up to extend, you can't stop it. You're still pulling yourself forward. Hip flexors and what? Lats. So it's I always would, and I know you guys do a great job of this, but I would say, what do you sense? Pat's a weightlifter, but she doesn't put weights in people's hands. She listens to how they speak. And if they don't speak well and they don't control their voice, she's not a good weight trainer. In other words, for you to be able to lift any weight, including your own weight, you better have that control first, because if you put anything in your hand, you just made them a puller. So I can't say never, Gibby, because you know that there's people out there, there's surprises out there sometimes too. You say, man, I really sized this one up wrong, okay? Did that answer that? Everybody's an individual. I want to really get this question, Jen's going to cut me off, because you wrote it and you were gone, okay? So I'm going to read it, okay? And then we're going to get into it. Is that okay, Jen? I need some clarification. Did you write this one down? Okay. I want to know how come I'm so doggone smart with PRI. Well, it's because I think you were really trained by the right epigenetics. You chose the right mom and dad. No, joking. Just joking. Need some clarification on treating piriformis syndrome with contralateral glute max. I love this question. Only question written that's in the manual that we haven't covered. Isn't that cool? That's why she chose right mom and dad. It's coming up. We're going to talk about piriformis. There's a left one and a right one with contralateral glute max. I want to say this right now. If you have a piriformis syndrome on the right side, in other words, a gapping on the right side, which you're going to see a lot of, those guys are pretty easily treated if you can get a glute max to fire with them shifting over to what direction? The left, because you're going to seal the deal. This program for non-pathology will seal that deal. We already kind of know that. If you got a left piriformis syndrome, you pass it on to somebody else you're working with. Because left piriformis people are going to drive you nuts. Left ACLs are going to drive you nuts. Left SI problems are going to drive you nuts. I'll just tell you that. Left piriformis people are going to drive you nuts. Left piriformis people need left piriformis integration. That's why you colored it yellow yesterday. It has to pull that anomalous that's going out on the inside together so you can get posterior shifting back in that capsule. So left piriformis, which is coming up, Jen, correct? We'll go over that. Here would be the algorithm I would use for left versus right. So if you can bear with me, we're coming up to that. I just want you to know we pulled your question.